So I hope everything is visible to all of you. Let me introduce first my center. So it's a Swami Rama Himalayan University. Swami Rama is one of the saint and well famous in USA and India. So he started a medical college that has a cancer research institute in the Uttarakhand that is known as the Devbhumi. So the topic assigned is a choice of place and regrets among caregiver of terminally ill pediatric malignancy cases. So I am associate professor in pediatric oncology and BMT program in this medical college, and I wish to present the presentation on the following topic. So first is what we are doing in this aspect, that is an ongoing study and results. I will discuss that. Then we will discuss about the literature review about this topic, which is having an emotional and social component. And then, if time permits, we can discuss. So all our experiences. Now the presentation is based on a study which is ongoing in our pediatric oncology department at this medical college. The part of the study was published in 2020 in supportive care cancer, and that part is we are continuing the study. So I'm just going to present that. And to disclaim, there is no external grant or conflict of interest to declare. Apart from that, it is published partially. So why we choose the topic, why we are concerned about it, despite all claim of curability and good results, stats of 2004 is showing that 22% of all childhood cancer cases will die ultimately, either related to disease or related to events. And data from a country like India, which is still developing, and a country which is underdeveloped like Africa and other countries in Asia, the data is not there. So more of the children cases, cancer cases, actually they are dying. So there is something to see with the death as a clinical outcome. And considering that, we thought of drafting a plan. So one more thing came to our mind, that our children, they knew about death. Yes. So enough study, the JCO 2000 study by Hilden et al., they show that children will often know when they are dying and may feel tremendous isolation if they are not given permission to talk openly about illness and impending deaths. And the second Journal of Pediatric Healthcare, 93, the long back. Then the writer Sconfeld DJ, they have written a beautiful line that a 13-year-old girl with widespread disease recount to the therapist, I know how to read palm and I read my own. I will be famous, I will be married once. I see a break in my life when I am 17. I wonder what that is. So, two studies, that is not only emotional ground. The science also says that the death is a clinical outcome. We cannot shy away from death. It is happening in a large proportion of kids of the malignancy. We need to properly deal with it. So death should be smooth, pain-free, should not leave a scar of deficiency in care. So place of death, where to die is not well defined. It all depends on the logistic. So we analyze in the study that the family preference of end-of-life care place in pediatric oncology cases who were destined to die because of the refractory nature of disease or otherwise, and the associated regrets of the parents. That's a retrospective recall study. So, and it's an observational qualitative study was planned. The parents and caregiver of non-curable pediatric malignancy patients who died during the year 2016 to 2019 were interviewed using a pre-formed open-end questionnaires that were validated earlier. The choice of place of terminal care with reason why they chose it, fear during the last phase of child's life, most disturbing symptoms, and regret of caregiver, if any, were noted and analyzed. So this questionnaire were validated in pilot project first. It has 6 parts that encompasses all the most common symptoms. Like first is question regarding suffering of the child during a terminal month, in which we divided into 5 the most disturbing symptoms, other symptoms of concern. then availability of medical help, effectiveness of medical intervention, and grading on the scale of 0 to 5. Similarly, about the fear, about the time lag between the understanding of incurability and our explanation, and alternative treatment, whether they seek or not, and what's their plan of care, and any regret or reason of regret. So we devised a questionnaire, we validated it, and retrospectively we send it to the parents either for a telephonic interview or they can come and do the interview. So result, total of 302 cases enrolled during the study time with our pediatric oncology unit, and 34 expected death noted among children on treatment. We only included a death that was expected. We excluded a death that was sepsis, bleed, or anything in otherwise uh, unexpected way in a pediatric malignancy. The median age among the 34 cases were 12 years. Male to female is 10 to 14. Male were common. And the respondent, 38% were mother, rest all were father. A telephonic response was compiled from 14 parent, and median time of declaration of incurability and accepting by parents is 3 months. So what we got is the most disturbing symptoms in terminal month is pain. The grade of suffering is 3. Most bothering fear of parents is pain. Most complained fear of child is separation. Median time lag is 3 months from the declaration of incurability and family acceptance of the term. Alternative treatment, 11 children took the alternative treatment in Ayurveda, homeopath, or Unani, or any other non-scientific treatment also. Choice of terminal care place, the home was chosen by 24, and 10 cases they actually die in hospital, selecting the hospital care. A retrospective regret of choice of terminal care were noted in 16 cases. So we divided the home-based terminal care versus hospital-based end-of-life care, and saw the parameters like literacy. It is 8 in home-based, 5 in hospital-based. Uh, uh, Illiterate is more in home-based. Self-financed or partially sponsorship, we found that home-based care and hospital-based, we thought initially in hypothesis that probably the finance is one of the reason, but it was not there. So self-financed, it was there, but the self-financed, they actually took 15 cases, they took them to home. Sponsored were less opting for the home, 9 out of total 13. Male is to female, 13 out of 13 male and 11 female, they chose the home based, while 7 and 3 hospital based. Regret of choice, that was the most important part, was found in 10 cases, 10 parents of the home based EOLC opted, and 6 step on hospital. And what was the regret? The most disturbing terminal symptom was pain in the home and in hospital respiratory distress. So why it is important? This is not a simple presentation. We thought about it. Like our 25% kids are going to face it. So let's plan it smooth. So their place of terminal care is not related to literacy or exactly related to sponsorship, although there is a tendency for that. But we can't say that all sponsored will opt for hospital. A regret of choice is more with hospital selection and terminal care retrospectively. At hospital, pain was better managed. That may be the reason that respiratory distress was main concern. While in home, the pain was the main concern based on home-based terminal care. Ease of getting temporary relief in symptom was notable in hospital-based care. However, 6 out of 10 participants still regretted the decision of opting hospital, and the concerns were a restrictive atmosphere, non-segregation, lack of privacy, fear of death in child due to frequent medical and nursing intervention. So mainly the death itself is coming, but the hospital is making an environment of death. That's what they explained. The 3 families who opted for ICU care and resuscitation regretted it later, as ventilation and sedation caused separation from the child at terminal time. Unavailability of home visit team or doctor was the most consistent complaint in home-based care. Availability of morphine was also a concern. So now coming to our review of literature, what we found and what the literature says. So coming from the India data, the data is not so crisp or not so frequently noted. So there is one pharma company, Cipla, which did a Cipla Palliative Care Institute, and which noted that 83% of Indian cancer patients opt for home-based terminal care. And the main reason was financial, but these were not pediatric. That was all age group, and that's true. But in our case, even with the sponsorship, the chances of opting home care was there. No clear guideline for the child care of dying child, because a child is not going to express their desire, or often we fail to ask the desire, what do you want? Data from this country is limited, but it's not like everywhere the scene in India is not good. It's like the WHO has applauded the community-based palliative care facility in Kerala. Kerala is one country with 100%, one state with 100% literacy, a well-established community model of healthcare, and they show that palliative care alliance can be done at community level. Although unfortunately, it is not followed in majority of states. So coming to the literature from other area, Noriyaza et al. They published a recent publication in Supportive Care Cancer, January. It is 144 pediatric palliative care cases in Madrid, where the home care team was structured, available, and committed to home care palliation. 70.1% died at home out of the all 144 pediatric cases which were destined to die. And the worry was still 91.8% pain, breathing difficulty was 49%. What we got is home is preferred, but pain is still the most troubling issue despite the home care team availability in Madrid. So Van der Geest et al., they published an article in 2017. So they did a survey of general practitioners who were involved in pediatric terminal care. 91 general practitioners who took care of 93 terminal cases actually responded to the survey. Uh, they, as per GP, the terminal feature, worrisome feature in pediatric cases were fatigue in 67% and pain in 61%. So, but what we found that if a general practitioner was involved, there is less shock or panic at the death scene. Only 2% family, they went into panic at the death of the kid, and shock or haste decision were less than 5%. So the coping of the family with the death in a support with general practitioner was much better. However, the burden shifted to general practitioner, and they showed their stress score 6.9 out of 10. So community support with GP is very useful, very helpful. Smooth death is feasible if the community general practitioner, they took the responsibility of being available and taking care of need. Noesam et al. In the recent publication, they pooled the study. This is published in PBC, Pediatric Blood Cancer. So they pooled 15 studies, 333 children with palliative need. So 58% died at home, 39% in hospital, very few opted for hospice. Factor favoring home, they found that parents' wish, patients' wish, familiarity of environment, these three. And who is favored hospital is if there is a trust on staff or logistic support, or there is safety concern regarding the careers. So home versus hospital is personal choice based on the issue what they are finding it more important. So that's how that there is a choice biasing based on many reasons, and both places, it is not only finance or literacy, both places are going to be there for a terminal care kid, what we infer from this till now. So how we can improvise our palliative care at hospital and home? We cannot shift all the kid to hospital. We cannot shift all the care to home. That is not practically feasible because the choice is variable. For home-based terminal care, I will just focus on what our study found and what literature review showed to us. Each country has a different setup, so probably they will have a different robust mechanism to help. Now, we proposed and we are trying to implement it in our state, that use of telemedicine to counsel or communicate about day-to-day care or about uh, the concern which can be managed, like a constipation, pain, sleep medicine, anxiety, these can be managed. So we are using now telemedicine to counsel and communicate. Issuing morphine in bulk from in pharmacy, because morphine availability is a big issue in our country or in other developing or underdeveloped country. So we are issuing morphine in bulk without even seeing the patient on the terminal care. So morphine itself over last 6-7 years, I can say the availability has much improved. Now we are issuing letter. So letter requesting nearby GP or healthcare worker to help. We are writing that, okay, this kid is this metastatic disease, and the outcome is not good. So therefore, he's for terminal care. So following points can be helped out at your center: oxygen, IV fluid, painkiller, nebulization, or even a blood need. And then we are teaching parents to cope. So these four things can actually mitigate the regret in a setting of home-based terminal care. Now, for hospital-based terminal care, what we are trying or what we have found useful is one is single room concept. So one of the regret, if we remember in presentation, was lack of privacy. So now we are providing them a single room, or we have allotted 2 rooms for the terminal care, where a family can sit with the kid, no restriction to attendance. We can arrange activities near child, so he should not be feeling left out or feeling segregated. So a playroom concept or a teacher going there or giving them something to do. Um, then liberal policy for caregiver. It's not like only one attendant or no one can visit. We are allowing the people to visit once they give consent for terminal care in hospital based. Then music, entertainment, television, mobile, these things are important to keep the kid busy. So that's how our suggestion came from our study and review of literature. So thank you very much. If the time permit, and we did a study since last 4 years, we are doing it. Anybody want to ask anything, most welcome.
Thank you, Dr. Kunal. Now floor is open for the presentation. Like anyone having further questions, you can proceed.